How are you all this morning?
Thank you. We are fine. How are you, Dr. Barron?
Very good, thanks.
Hello, dear followers of our channel, the YouTube channel of Association for Community Mental Health Promotion. Today, we have a very valuable guest among us, Professor David Barron from Western University, California. And we have 3 students among us, and Canan Hepdurgun is the co-moderator. First, before we start, I would like to say a few words about David Barron's background. It is such a huge document. I asked his advice and tried to put it in a shorter form. I would say he's a professor of psychiatry and provost and senior vice president of Western University Health Sciences. He's emeritus professor from University of Southern California, former deputy clinical director and director of education for National Institute of Mental Health. There is a long list of places where he has worked as teaching, as professor, several medical schools, social work, nursing, psychology, dentistry, PT/OT, that I didn't understand what it was, graduate school, optometry, podiatry, interdisciplinary education. And there are, maybe I should have asked it before, but I didn't. There are several letters bringing together, I'm sure, very important names. I will skip them. I will just say he's a board certified psychiatrist and neuropsychiatrist also. He's also board certified in brain injury in medicine, and he had fellowship in training in consultation and liaison psychiatry, and also in medical education. He has worked in WPA, World Psychiatric Association, at different sections on that psychiatric association, I should say. He was the chair of sports psychiatry section, and I think he was the founder of that, if I'm not wrong. And he and me worked together in the education in psychiatry section. And now he is chairing the section on psychiatry, medicine, and primary care. He has also been on the executive boards of several organizations in the United States, and also in several international organizations. He had visited Turkey as well, and he had attended some of our national congresses, and he had visited the main place of our association, Kocaeli University. And maybe I should stop here. David, we are very proud being together with you, and we will be discussing interdisciplinary collaboration in education. Of course, there are different aspects of it, but you are an expert in this area. May I leave you the floor, if I may?
Thank you so much, my friend. Can you put up my slides just to give us some structure? Or
may I do it? Do you want me to do that?
Yeah, if we can. I just don't see a shared screen here. I have the slides up.
All right, I can put it if you like. I'll try.
Okay. I have them up on my computer. There's just a few, but I think it'll give us some a little bit of structure. So well, my good friend and colleague of many years, Dr. Koshin, I want to thank you. And I really want to thank our junior colleagues who have joined the call, because as you'll see in one of my final slides, I only have a few, the future of our field. And I'm not just talking about psychiatry, I'm talking about the field of healthcare and mental health care delivery really lies in your hands. What I'd like to talk about today is kind of the role of collaboration in health profession education. And one of the things that I've seen, thank you, Willem. One of the things that I've seen in my career has been the change in the culture of education. Physicians, not that many decades ago, really tended to function more independently. If they were in a hospital, if there were nurses there, the doctors worked, the nurses really were there to help support the physicians. But the problem, as I see it, is that there was never strong collaboration. And what I'd like to talk about today, just to get things going, I'd rather this be a discussion. I'd like to hear your feedback from all of those on the call, is if we've learned one thing from this terrible global pandemic of COVID-19, it has taught us how important it is that we all work together in the health professions, and that it's not just the internist or the emergency room physician, but it's really all areas of the health profession. And this really begins with education. So if we can go to the next slide, please. Oh, so they're just on my
Oh, sorry.
Oh, it's a drop down. So I have no conflicts. I have no involvement with industry, and I've written some books and a number of papers on psychiatric education. One of them with my the host of this meeting today, Professor Koshin, and it was a joy to do that. So the delivery of healthcare is clearly evolving. It's become a team approach, where in the past it was much less so. I think one of the important issues that I'd like for us to discuss today in the time that we have is we're understanding now how important cultural sensitivity is. So it's not just getting the knowledge that we learn in our various disciplines, whether it's nursing, psychology, social work, medicine, but it's understanding that information from the perspective of how does culture affect this. Certainly we see culture and cultural beliefs are having an impact on people even wanting to get a COVID vaccine, that depending on the cultural background that they ascribe to, this is one of the best predictors in the United States on whether you're going to get a vaccine or not is your political affiliation. So clearly that has nothing to do with science, but culture is so important. The other thing that I think that I've learned so much from my dear colleagues and friends in Turkey and around the world is who really is the expert. I recall having discussions with Bülent when you had the terrible earthquake a number of decades ago now in Istanbul, and experts, and I put that in quote, from around the world came over to help out. But in reality, were they really the experts? Maybe the true experts were the people who had been there, who understood the culture and understood what the needs of the people were, as opposed to someone who maybe had many degrees, but in fact weren't really an expert of the needs of the patients and the populace who were there. So I think it's important in this regard that sometimes the experts in taking care of the patient might not be the physician, but maybe the nurse who's been seeing the patient every day, saw how they were sleeping, saw what their mood was like during the day. Maybe the real expert was someone from social work who understood what the family dynamics were, what was going on with the patient, what were the stressors at home, be it family related or occupational or financially related. So I think it's important that when we talk about who is the expert, the answer to that is there are many experts. And the way we provide quality care and quality education is to acknowledge that we can learn from all of the experts. We certainly know that there will never be enough providers, whether it's psychiatrists, psychologists, physicians, internists, teachers, that we just won't have enough. So the need for us to work together to expand capacity becomes very important. We call that the multiplier effect. So if we have, for example, one psychiatrist who might be working with 4 or 5 general physicians, or working with a team of psychologists or social workers, or a psychologist or social worker who's working with a group of students who are going out into the community and working with patients and their families, then we can provide more in the way of care, but by all working together, not by having one person for one patient. The next part of that slide is co-location. So what do I mean by co-location? You might have in a hospital physicians, nurses, subspecialists, psychiatrists, cardiologists, but they're just kind of in the same building. You might have an outpatient doctor's office where you have an internist, and maybe within that same building, you might have a psychologist or a social worker or other behavioral health specialists. But if they're not really working together, they're just co-located. They're essentially living in the same neighborhood, as it were. The important part of healthcare education as it evolves, and what we need to focus on right in the early parts of professional education, is having people not only be co-located, but be embedded and integrated. So if we have different disciplines working in the same building, whether it's a hospital or an outpatient clinic, is that they clearly are working together. And I'm going to talk about a project that we've had at my university that's been very successful. It has to be a real life demonstration. What's really going on? Too often, patients will come into the hospital and the physician might treat the signs and symptoms that resulted in them becoming admitted to the hospital, but they don't take into account what it will be like when they go home. The emotional, physical stressors that might result when the patient goes home. And oftentimes the patient does better in the hospital, but goes home and goes back to those stressors that were not resolved, and their physical illness returns as well. And we all know that physical and mental health are very, very closely related. In fact, they're one and the same. The old saying we've heard time and again, there is no health without mental health. Collaboration becomes so important. It really starts with collaboration in education. It's what we're talking about today, that collaborating in health professional education, and not just lecturing on how different disciplines should work together, but have them be together. And we're going to talk very briefly about that. This is a bit of a cultural shift, certainly for those of us who were trained many years ago, that this was not the way we were trained. But I believe this is the way current and future providers should be trained. The culture of working together, of appreciating the expertise of students from all disciplines. And in fact, being able to acknowledge that students in different disciplines are just as important as maybe those who are making more money because of their degrees. But in fact, the cultural shift, I think, will really result in not only better clinicians, but better patient care and better public health. And there's no better way than to learn together. Next slide, please.
At this point, can I ask you something?
Of course.
If we go back, this culture shift is very important, I understand. And how is it going to be? Maybe you are going to tell it, but I'm a bit, how should I say, a bit anxious about to hear that. When you say they learn together, do you have the students in one class?
It's the perfect setup. That's exactly what I'm going to be talking about, because the way we change the culture is by changing from the very beginning. Cultural changes must start at the beginning, and it takes a little bit of time, but I'm going to demonstrate, I'm going to share with you some projects we're doing that will address this. And I think if an individual is trained in this fashion, then that helps to begin to change the culture. So if we can go back to our full screen, yeah, we can go through it. The next slide there. Oh, I think we skipped through one.
Yeah, I can't stop. I'm sorry, I'll come to
what we want is slide number 4. There we go. So when we talk about collaborations, there are different types of collaboration. Now, this is taken from the CD Education on research that's been published worldwide, but we talk about multidisciplinary collaboration. So this is when we're working with people within their own discipline on a perspective that's similar to others. Then we have interdisciplinary, and this is when we're working together on a common problem. Maybe it's COVID, maybe it's substance abuse, but from the respective perspectives of each discipline. So this would be people coming in and saying, well, this is my perspective as an internist, or as a psychiatrist, or as a psychologist, or a social worker, or a public health provider, or someone involved with public policy. But it's really kind of staying in your lane, as it were, from your own perspective. And then we have this, what they call transdisciplinary, which is approaching a common problem from an integrated conceptual framework. And in this way, we kind of redefine the problem and solution, not just from the narrow lens of your own discipline, but really working together in how do we redefine this, not just looking at medical or other areas. And then, so that's just a broad stroke. If we go to the next slide, then we're going to get into Boulam's question. What we do at my university, and just for those of you who don't know, Western University is 9 graduate colleges. So we're actually the most diverse in the United States, but we represent 9 different health disciplines. And there's a wonderful opportunity when we have students from 9 different disciplines on one relatively small campus. And what we do is we've developed, and many of them, there are many institutions that have this now as well, what we call it Interdisciplinary Education, or IPE. And the way this works, and this is how we're actually starting to change the culture, is we have case examples and we have facilitators who can come from different disciplines. They don't have to be physicians. They don't have to be psychologists. We have nurses. We have physical therapists, occupational therapists. That's what OT is in the United States. And what the students do is we have students very early on, at their very first year of their training, from all the different disciplines in a room together. They review the same case, and the facilitator has the students talk about how they look at the case, but how they would work with others. So the medical student in the group might look to the nursing student in the group and say, well, I don't really do that. How would you do this? How can we work together? And this goes on for the whole year. And what we see over the course of the year is the disciplines learn that they need each other. The visiting nurse that goes out to the home can provide information that the doctor might not have. The psychologist or the social worker might be able to provide a perspective, but they're working together on how to understand the patient from this transdisciplinary, this multidisciplinary perspective. And they understand that taking care of the patient requires an understanding of what's going on in the family, what's going on in the community. And again, we know how important this is just from COVID, that many believe that the most devastating effect of COVID is not the death, which is certainly terrible, or the number of positive cases, but the effect that COVID has had on the community. Children not being able to go to school, not being able to socialize, what the impact has been is but being isolated, individuals losing their jobs. So the role of the community as a determinant of health and mental health really becomes prominent when you have people who are being trained in that area. We found that adding students from even disciplines that we don't treat, that we don't train at our university, we bring in students who are studying public health, public policy, government, education. And when we come together in an interdisciplinary fashion, not only do we learn from each other, but the perspective starts to change. And we've actually seen that, where people, when they get a case, they call, the first thing they do is they call and see what's going on in the school system. What are the public policy issues, public health issues that might be affecting this? So I think we start to change the culture when we start to change the educational model. And the model is that we are here to collaborate, to work together, to address health of which mental health is such a critical component. Next slide, please.
Again, can I ask something?
Of course.
Sorry for interrupting you.
Not at all.
Just to see it in my mind, how many students would be in one case discussion, case presentation?
We try to keep it around 8 students. And now I'll be perfectly honest, what will determine it is we go out and we train our facilitators. We want the facilitators to know how to, they're not there to give a lecture to 8 students, but they're there to facilitate the discussion. So all the students get a copy of the case report. We spend a good deal of time developing these cases, but they don't have all the answers in it. They really raise a lot of questions. So the role of the facilitator is to make sure that all the students, so if the facilitator sees that maybe the social work student or the student from a different discipline isn't engaged, the facilitator will then say, what is your perspective? How might you help? Because sometimes we have a student who might be a more assertive could sometimes take over. And it's not unlike what we learn in psychiatry and doing group psychotherapy, that we learn to facilitate the interaction of all the disciplines and the respect that we need to show each other. We found 8 seems to work well. If it gets too large, then it's difficult to have everyone engaged. And we believe this has to be active learning. Everyone has to engage in the discussion. Everyone has to say, this is what and they learn from each other. And it was very interesting. Our university became a COVID vaccine clinic. So we were giving out vaccines. We were approved by the government. And I had my students from all the disciplines, not even just the health discipline, who helped out in that. And we had nursing students obviously giving vaccines. We had the medical students, even our veterinary medicine students. We have a vet school at our university. But the students who weren't giving the shots per se were part of the team. They were helping the patients sign in. They were engaged in the process. So the people who came through to get their vaccine saw how all of our students were working together, getting health histories, making sure that we had our social work students were helping make sure that there was transportation if people were having difficult time getting there. So what we did is this became a working model where the students were all working together in the clinic the way they work together in the classroom. So we found the 8, sometimes we have to go a little larger if we don't have enough facilitators. I don't like to go much less than 6 because then we don't get that sense of the collaboration and the discussion that goes on between the different disciplines and not being right or wrong, but how we can work together to provide the highest quality of overall healthcare.
Do I understand correctly? None of the students, 6 or 8, are from the same discipline. They are all from representing different disciplines. Is that so? Correct.
So we will, if we try to have 6 or 7, we might have, again, depending on the number of students, but we want to make sure that each of the disciplines is represented. And when people get in, they introduce themselves at what discipline they come from, so people know. And then we set the stage, as it were, in the discussion that this isn't about their individual discipline. This is about providing the highest quality of care for the patient. And in the case, we make sure we give information about their socioeconomic status. Again, our university is in a very poor part of eastern Los Angeles County. So many of them, many are homeless. So, how do we provide care for someone who's homeless, who might be living, out of their car or going to homeless shelters? So what we do is make sure that for it to be true IPE, we must have representatives, student representatives from each of the disciplines. And then we must take how each of them, not only what they might do, but how they can work together. So we get the doctors to make sure that the student doctors, to make sure they're asking the nurses and the students from social sciences, do they have access to a refrigerator at home? Can they store their medications? Are they able to get to the pharmacy? Do they have the resources to buy their medicine? Because sometimes the physician students might be recommending medications that are very good, but the patient will never be able to afford. So we try to make this a very The cases were developed. They try to make it as close to the real situation. Oftentimes, they're based on actual patients. I've actually written one of the cases myself. And we found that this starts to change that culture of really, truly working together on providing highest quality care for the patient.
Excellent, excellent. And the number of classes are limited with the number of facilitators.
Well, that's kind of a rate limiting step. Now, what we found is that many of the original facilitators felt that they could only teach medical students or nursing students because they felt comfortable in their discipline. They said, well, I don't know how to teach a medical student or a nursing student or a social work student or a student in public policy or public health. So we actually train the facilitators that they're there to learn as well. And it's been very interesting that some of the greatest cultural change has not been with the students because they're learning the culture. It's been with the facilitators who grew up really only working with or realize maybe a nurse is only to go in and to change the bedpan or to make sure the patient gets their medication. So we've had some really interesting responses from the facilitators saying they never realized how important it was and how much information they could get from working with people from other disciplines, particularly those not in the healthcare directly. So public health, public policy, government, and we bring in educators. So we have a person that comes in from the school district, a teacher, some of the students who are involved in becoming, they're going to become teachers, talking about, what they're seeing, a student who's late for class or keeps missing class, or maybe is coming into school and is very hungry. In the United States, many poor students get the majority of their meals at school if the family is in poverty. So, so again, we do the best we can, but we found that when we start doing this, the interest gets stronger and stronger, where we're getting more and more facilitators. Now, what we're finding is that we have students who will literally come in and apply to our various colleges. And one of the things they ask on their interviews is, when can I start my IPE? So that makes us very happy that students are actually thinking this is maybe a good or a better way to develop their undergraduate training, as it were. So the role of the community, and I think this is something that I know I didn't really get much education in when I was going through medical school now over 40 years ago, but what I've learned to really understand is such a critically important part of overall health. And this is why we get community leaders, we get politicians from the local community who will come in and talk about things. But I think if we as healthcare providers understand that one of the most important parts of our collaboration has to do with understanding what is the role of the community. And this gets into culture, not just the culture of healthcare, but what's going on. We know that there are political issues that play a very important role. I think we need to understand, and we all learn in our schooling about the biopsychosocial approach, but I think we need to look at this from the biopsychosocial approach from a community perspective. What are the biological aspects going on within a community? So I live in Los Angeles. In fact, we get some real extremes of weather. We get fires during the fire season, and they've been getting worse and worse with global climate change. Oftentimes after the fires, there's very bad air. So children or adults who have any kind of pulmonary problem, this becomes a very significant issue. So I think part of what we believe is important in this collaboration in healthcare is to make sure that all of our students from all the different disciplines appreciate the role of community. We find that the social work students in the United States oftentimes are much more knowledgeable and spend a good deal of their training understanding how to use community resources. That's something that oftentimes when I was a student, I didn't even know. So now we've got students from our pharmacy school will come in and help provide information on the costs of medications, how students might, and they work with the social workers to see how they might be able to get their medications less expensively, or understanding that that giving a medication 3 times a day for someone who's homeless is virtually impossible. So they'll help the students understand that maybe a medication that is not quite as good, but is adequate, but only needs to be taken once a day. We certainly see this with the vaccines. a vaccine that you only need one dose is much easier to get out than a vaccine where you need to get a second dose, when oftentimes patients or citizens might have a difficult time getting back for that second dose. We've already said it, but I think it's worth repeating again that there needs to be respect for all of the stakeholders. And I'm not just talking about the healthcare providers, but respect for the patient and their families. One of the things that I learned in my psychiatric training, and I had some special training in family therapy, is that just interviewing the patient was fine, but I really needed to understand from the family's perspective what was going on. And not to see whether the patient was being honest or not, but getting a sense of the dynamic. And I think, again, social work students in the United States oftentimes are very good at this. So if we have respect for all of the stakeholders, I think it makes for not only a better collaboration, but it also, I think, helps change that underlying culture. Everyone needs to take ownership of the success and the failures. Now, what do I mean by that? That oftentimes the physician will say, well, no, I've treated this patient's hypertension or their diabetes or whatever it might be, and feel that they've been successful. And then the patient goes home and doesn't adhere to the proper diet, or they still have the ongoing stresses that might be going on at home or at work. There are cultural issues, there are political problems, and then the patient doesn't do so well. Well, the physician feels, well, I've been successful, but no, they've really not, because health is something that goes on 24/7, not just when you're in the hospital or sitting in the doctor's office. So if the team works together to take ownership, then it becomes important. Then the doctor understands the importance of what's going on at home that they might learn from the social worker, what's going on at school or at work, what's going on from a public policy perspective that might be affecting health and well-being. And again, this is all that we talk about, this transdisciplinary perspective, looking at the problem, not just through the lens of your own discipline, but through the lens of how can I affect overall health and well-being for my patient and their family, and the health and well-being of the community at large. Next slide. And it looks like future opportunities, and I think, and then I want to close for some questions and comments. So what are some future opportunities that we have to look at? Well, I think in the area of health education is one of the potential silver linings out of this very dark cloud of COVID. And I feel so terrible for our friends and colleagues and citizens of India. We're seeing the news of the unbelievable expansion and of cases there, and it just makes me sick to see that's going on. But all over the world is that COVID has taught us that there are other ways to learn. Look at this lecture. We're able to get on YouTube or Zoom or Teams, and we can do a lecture from all over the world. It would have been very difficult, if actually impossible, for me to fly to Turkey to engage in this, as much as I look forward to doing that in the not too distant future. But we need to expand our online education. And by education, I'm talking about having a call like this, where on the Zoom call or on the YouTube, we have students and professionals from different disciplines. I know Boulant ran just an excellent program just a few weeks ago, where they had this speed dating, which I thought was an interesting concept, but literally people could get on with one-on-one on the Zoom for a few minutes to discuss, and Boulant just showing his excellence and expertise as an innovative educator. There are collaborative grants, and oftentimes it takes money to do some of these things. Oftentimes not a lot, but if money's not there. So there are funding agencies where we can look at saying, you know what, it's important. We've gotten some grants at my university focused specifically on training individuals from this IPE, this interprofessional education. And it's not that expensive. You can make it expensive by doing very high-tech things, but what just as well, it was having students, 8, 9 students, 6 to 9, 10 maybe, sitting in a room with a facilitator, going over a case and just discussing it. And I can tell you our students really, really enjoy this. In fact, many of them say it was one of the highlights of their training. And we do it throughout the entire first and second year. I think the interaction of professional societies, the American Psychiatric or the World Psychiatric, working with the World WONCA, with the family practice, or with the World Psychological, or with, each discipline has their own, not only national, but usually world, and our societies need to work together. And again, that helps change the culture. So education, but then clinicians working together, educators from different disciplines working together to really develop this culture, but to provide a real bedrock of solid collaborative education. And then I think this is all built on the bedrock of creativity and innovative leadership. Leadership both within providers, with educators, and then with students. I found that the students play such a critical role that they're the ones that can educate me and the rest of us on how they learn best. They can educate us on the role of internet and internet technology, which I'm not an expert in at all. So part of the cultural change for us is to have the students appreciate how important a role they are. They're not just there to be a passive recipient of education and then get 75% correct on an examination and then get their degree. It's much more than that. It's their active participation. They're asking the good questions, and all of us learn together. And that to me is not so much innovative, but something that we need to never lose sight of, that students are a critical part of this. And in fact, the quality of the education will never be as good if we don't get students actively involved and feeling comfortable in raising their voices, in asking questions. And in fact, the facilitator's role is to make sure that it's the students that are at the core of this cultural shift, and that they're the one that are taking the lead role with the facilitator there just to make sure that the process stays on track. So I went a few minutes over. Boulant knows that's a very bad habit of mine. I always I'm passionate about the things I do, and that passion oftentimes lends to not being the best in following the watch. But I would like to, as much as we're able to in this session, have a discussion, some feedback, questions, and really I'd like to hear from our audience on how can we make this better? Because at the end of the day, you, our students, our junior colleagues, are our future. Thank you so much.
We thank you a lot. I'm stopping the sharing now. Come back. It was excellent. Thank you very much. With your permission, I would like to correct one point. For the recent workshop, it was not me, or not only me, but Franziska Bassler from Germany, who had this excellent idea of having a workshop with speed dating and all the others. And as well, Cenan was the creator of those 50 rooms at the same time. It was, as you keep saying, a teamwork.
That's right. And a team, when we have a team, if it's a football team or whatever, basketball team, not one person work, the whole team wins. So this is really, I think, thank you, Boulant, for mentioning that collaboration is about everyone being happy with success. It's not one person, but it's the team. And the team can help each other and learn from each other. And you're right, it was just an outstanding, and I know some of our junior colleagues were involved, but it was an excellent opportunity. It was innovative and creative, and it showed how we are always better as a team than we are individually.
Exactly, thank you. Now, dear young colleagues of ours, who would like to say a few words? Sorry, I couldn't stop myself and interrupting while he was presenting. I still have several questions in my mind, but I shouldn't take time of yours. Who would like to start? Please, please. Melissa, could you first, I didn't do that. Could you first say a few words about yourself?
Yes, of course. Firstly, thank you to dear Dr. Baron for your great presenting. Let me introduce myself. I'm Melissa Bulut. I graduated from Hacettepe University Nursing Department, and I'm currently a master's student in mental health and psychiatric nursing. And nowadays I write up my master thesis, and I'm also interested in psychotropic medication management, evidence-based psychiatric and mental health practices, and psychiatric nursing education. Nice to meet you. Thank you again. I have a question to you. You talked about COVID-19 pandemic and you talked about IPE program. And I wonder that how the COVID-19 pandemic affected interdisciplinary education in psychiatry, and what kind of did you use education strategy in IPE program in
Well, first
this
of all,
process?
nice to meet you. So we just got a grant at our university to develop a psych nurse practitioner. So in the United States, a graduate nurse, and it sounds like that's kind of what you're doing. So, so congratulations and best of luck with you. What COVID did is, unfortunately, it didn't allow us to meet face to face. So we've continued to have our sessions, but they've been on Zoom calls. And I must say that although the Zoom is okay, I can tell you it's not the same as being face to face in the same room. We're hoping to go back this fall to face, but socially distanced, and everyone's vaccinated. So even the masks are, you know, we get big open rooms. But I think what we're seeing is that you could do an IPE program around the world. You could have an IPE class with a nursing student from Istanbul, with a social work student from the Ukraine, with a medical student from Milan. So I think there's an opportunity, although I would miss the face-to-face interaction, that IPE, you just get 6 or 8 people on the call and we can use the chat room, and we've all learned how to do that. And I'm sure your generation will come up with much more creative ways. But I think COVID might have given us an opportunity to literally expand IPE, where we have students maybe just within Turkey, from different cities, different universities across the country. Because culture, what I like is I learned about different cultures from people who live there. I've learned about Turkey from my dear friend, Professor Koshin, not from reading a book, from meeting his friends. So I believe if we're willing to be really innovative, we can take education out of just one institution, our home university, and reach out. And I've done this in our place. So there are universities all around where I am. There are a lot of colleges and universities in Los Angeles, many. I've reached out to different colleges and we start having their students. So they don't have to drive there, but we can do this. So I think, and it will be your generation to work this out, but I think IPE could be expanded. And we learn from each other. This is why we publish papers on how we set this up, how we got it funded. And I believe it's something that we should really take seriously about using this IPE approach and collaboration and defining how healthcare should and will be moving forward. So this will be your challenge as a future leader in your field. And in psychopharmacology, I mean, we're doing a project now in India, and we're finding that, that with antipsychotics, that long-acting antipsychotics are probably better when you can only see a patient once a month, when they can't get to the clinic because they're in a rural village. So again, we bring in social workers, we bring in nurses who can prescribe the long-acting antipsychotics. We get psychiatrists who oversee this. So I believe there's a national and an international and global perspective, and the success will really fall on you and your colleagues of your generation. Best of luck.
Thank you for your answer and explanation. Thank you.
How about some other questions or comments?
Well, Seda, please start with, maybe I should have done that, but please first introduce yourself.
First of all, thank you for this introducing this program to us. My name is Seda Öztürk. I'm a master's student at Maltepe University. My major is clinical psychology with body psychotherapy. This program was really important for me because I want to share my experiences in my internship. When I was interning in hospital, I felt that I was not part of the team. I felt the exclusion in my profession because the other professions were more dominant in the area. And that's why I really like the presentation, because it's a really good project. Now I would like to ask if we can expand this to hospitals. We don't have to be limited to university, because in hospitals, in the environment, we need this education, we need this collaboration, because in the application of this program will be really good.
Well, thank you for that comment. And I need to be honest with you. My idea to do this started when I was working in a hospital. So I don't know if consultation liaison psychiatry is a subspecialty of psychiatry, or psychiatrists who only work in medical hospitals. So I never worked in a psychiatric hospital till very end of my career was teaching. So I worked in a general medical hospital. And what our role was the physician would say, oh, I need a consult on this patient. I think they're depressed, or they're anxious, or I just don't know what's going on. So what I started almost 30 years ago now is when I would round for my patients in the inpatient hospital, I just didn't round with my psychiatry students. I invited the social worker, the pharmacist. I would bring people in. So I actually was involved because I said, it makes me a better doctor. And I learned. So I started a concept in the hospital. First, it was just a pharmacist and I said, bring your students. I want to learn from your students. So I would have a very big team that we would go and see the patient, but I would have physicians, social workers. I would even bring in other people, and they would bring in their students. And then after we made rounds, we would go back and sit in a room together discussing the cases from a different perspective. And that's how I got the idea of, let's start this when students are still in training. But my original plan, and when I first started doing it, was it just made me a better physician. I learned so much from students and professionals in different disciplines. One of the things that I think we need to change the culture is physicians are always viewed at the top of the heap. It's the most prestigious. They make the most money. And that's the same way pretty much all over the world. And what I thought was important was that if the patient gets better, we all win. And part of the culture change was I would look to the social worker and I'd say, I can't really understand this patient that well without understanding what's going on at home. And I said, now you're not at home, but what are the questions I should be asking? What would you ask as a social worker? And then we would start learning from each other. So it actually started in an inpatient clinical setting. I brought their students in. And then when I'm back now, running a fairly large university, I was able to bring it into right as the students start. So I think part of the cultural change does need to start with the hospitals. And then it needs to be a piece of the fabric throughout the entire process, from the time a student starts their training, literally the first week of classes, until the time that they're in advanced training. And then they're the senior attendings or the professors that we all work together. So it sounds to me that there's some work to be done at your university.
And it was not about my university. It was about the hospital. In the hospital, I felt that my professions were not important as others, because.
This is a very critically important point that you raise. Because it sounds like it's easy to do, but nothing is easy. If you do it well, it's easy. But I think one of these challenges that we need to address is to get beyond just the classroom. I was focusing on this today as education, but education really, maybe it's more important to do at the hospital setting. And we take it at the government level. So when we go and I consult with government officials, I make sure that I don't just go there alone, but I say, well, let's have a group discussion, but I need to bring in my professor in social work as well, or my PhD psychologist. So my brother's a PhD psychologist. So I have that appreciation. I have nurses in my wife's family. So, we have family discussions, and many of us come from different disciplines. But you raise a very, very critically important point. And that's part of changing the culture, is to make sure that hospitals see not only is it the right thing to do, but it's better for them. The outcomes will be better. It will be less expensive to take care of patients well And this is how we changed, like when I was up in Canada, I did a Fulbright. We changed the Canadian laws on some things, not because it was the better medicine, not because we included it, because it was cheaper. We were able to demonstrate that level of it, that it lowered the cost. And politicians are always interested in lowering the cost, saving money, less taxes, they get more votes. So I think, you know, this is a very complex problem, but I believe if we can demonstrate that everyone benefits from this, you know, what's in it for me, that mentality. And the more we appreciate the role of psychology, social work, educators, you know, public health officials, teachers, I bring educators in. As we are able to do that, then we start to change the culture, and then the quality of care gets better, and it becomes more efficient and more effective and more enjoyable for everyone. So there's a challenge there, and we need to rely on some of the more senior people, because it's difficult for you in your stage to go in. But if more senior people, or maybe somebody from outside, you know, the grass is always greener is a statement we have in the US. Like, it's like an expert from somewhere else is always better than your internal expert. That goes back to my first slide. But maybe having senior members go and speak to the hospital officials to say, you're going to save money, you're going to get better outcomes. Let's work together on this. Your hospital will become known as one of the best hospitals in the area. So you'll have that competitive advantage. So it takes time. Changing culture always does, but we have to start now.
Thank you.
Thank you very much for your encouraging words. While you mentioned your interdisciplinary family structure, I have forgotten to, I had in mind to mention at the beginning that, if I'm not wrong, your father was a psychiatrist, and also your son.
And my grandfather.
And your grandfather, yeah, 4 generations. And it's very interesting, of course, but I understand it's not limited with psychiatrists.
Correct.
Great.
My brother's a psychologist. I have cousins who are doctoral social work students. There are many nurses in the family. So I guess I grew up having an appreciation for all the hard work that everyone does. And that it wasn't just that being a physician or a psychiatrist was the most important. Maybe we got paid the most, but in fact, we could never do our job as well if we didn't understand and appreciate the critical contribution that other disciplines make, and really looking even beyond that. So I went back, I got a degree in education, and when I was training with my educational colleagues who were not in the health sciences, I learned so much about being a better physician by learning, because we all know the word doctor comes from the word docere, which means to teach. So at the end of the day, regardless of what type of doctor you are, doctor of psychology, social work, nursing, we are all teachers.
Thank you so much. Now, will it be your turn, Rojda? Please start with introducing yourself again. I left it to you.
Okay. My name is Rojda. I am 5th grade medical student in Hacettepe University, Faculty of Medicine. And I am interested in mental health and disorders now. And it's my greatest desire to be a successful psychiatrist, as you did in the future. So my question is about, actually we have a similar, at least as an introduction to interprofessional collaboration course in our faculty. And our difficulty is to arrange common time periods for interprofessional activities among different faculties. And another thing which creates difficulty for us, we have a real, there is too much information load on shoulders of medical students. So how could you relax the curriculum to implement this course to your curriculum? I'm really curious about it.
Well, it's an excellent question. So I've been involved with medical student education for most of my professional life. So I graduated medical school back in 1978. So that just shows how old I am. And this has always been the issue in medical education, the curriculum is too busy. There's no place. Where do we put it in? And it took me till I got to the point of being in leadership roles. So I've been fortunate later in my career. So now I guess it would be rector would be the equivalent in your system. So all of the deans report to me. So I'm the boss of all the deans. So it makes it a little easier to make things. But what I did is I asked them, I said, what's more important? And you've raised a really important point that we need to address. And this is part of the culture change. The culture of medicine is you need to have so many hours of anatomy, physiology, biochemistry. And what we've done in our place is we've actually changed our entire curriculum and made it a little bit less dense. It's not so much hours and hours of lectures, because that's the way it's been for, 50 years, if not more. Remember, physicians originally were trained as almost, they would just go and they would follow around another physician. They would be apprentices, essentially. And then it was a fellow named Flexner many, many years ago who said, no, to be a physician, you need to be trained in the classroom, and there's a science of medicine. It's not just having a trade, like a mechanic, as it were. So you raise the point, and I think what we need to do as educators, as senior educators, to say there maybe is nothing more important for this. So we rearranged our curriculum. It's built in. It wasn't an add-on. It was actually one of the keystones of the curriculum. So they had to, and it goes for that first 2 years, which is half of the medical education in the United States. You know, in the US, you go college for 4 years and then 4 years of medical school. In your country, in most of the countries of the world, you start medical school, you know, after you finish, you know, your 13 years of high school. So what we need to do is have this take place at the level of what should the medical curriculum of the future actually be. I would suspect we're going to have more lectures on immunology, you know, COVID, you know, things come up. So this is part of the cultural change. We need to change the culture of medical education. We need to make sure that social work students maybe have this opportunity. So this won't happen overnight, but I believe it can and will happen. And it happens when we have the students kind of saying, we need this education. For me to be a good physician, I need this. So the students oftentimes feel that their voice is never heard. And that's not really true. Certainly they're lower down on the hierarchy, but if student organizations say, hey, we've seen this, can we try this in our place? Can we work with our teachers and our administrators? So part of that cultural change is changing the culture of education and realizing that medical education, you know, missing one anatomy lecture or missing one other lecture maybe won't be that big a deal. So we can change that. And I can tell you, it takes some time, but it doesn't take years and years and years. It takes the commitment of people, as my last slide said, who are innovative and willing to say, this is an important part of becoming a successful provider of the future. We tell our students when they first start, we're here to train you to be the best provider of the future, not the best provider of last year or today, but the provision of healthcare in the future, physician, psychologist, social worker. So if we want to do that, we have to be forward thinking and saying, how do we prepare people for how they're going to be practicing their discipline when they graduate?
Yeah, thank you very much. Yeah, and how could you arrange common time periods for different faculties? Well, how could you do that?
Yeah, we actually started off by incentivizing. So faculty were doing this on their own, and we would start by saying, we'll give you, let you get some additional time to go to a conference, or we would pay them a small amount at the very beginning. Now we have faculty who are saying, no, it's my turn to be IPE because it's become so popular that the faculty are saying, wait a minute, I'm a senior to you, I'm taking the class, because the faculty enjoy it so much more. It's because it's not giving a boring PowerPoint lecture. Hopefully this wasn't too boring a PowerPoint lecture, but it's the faculty. So now I've got the other thing. Now I've got junior faculty saying, wait a minute, how come I don't get to facilitate an IPE? So as it becomes successful, and we've been able to change the culture. So now you have to earn the right to be able to be an IPE facilitator. Whereas it started off, we had to incentivize people. And again, that's understanding as psychiatrists, as behavioral health, we understand what drives behavior. So it's not just knowledge, but it's behavior and attitude. Now the attitude at my university is, if you're lucky, you might get to facilitate an IPE class. Now that took a little time to get there, but teachers really enjoy seeing the students becoming engaged and asking each other questions, not just asking the facilitator, but they literally have to ask the other students in the room. And as the students get further along in their education, they feel more comfortable in their knowledge base, and they really start. So it's a process that can be, I think, could be done. I would love to do this internationally, to do a little experiment, to have students either from different universities or hospital settings within one country, or even maybe internationally, so that they could share, well, in our country, culture says this, so we can appreciate the role of culture, because it's even within Turkey. We know that out in the countryside is probably different than Istanbul, and might be a bit different than in Kocaeli.
It's a very important point for us, and I hope we will have the same chance as you did in your university. I mean, thank you very much.
Well, you have champions. You have people like Professor Koshin, who has been a very senior person within not just his university, but within the Turkish government. So it's getting people, the World Psychiatric Association. You have some very prominent psychiatrists in Turkey. And then you have to work with the politicians. You have to work with the educators. I go in and do a lecture at our high school on behavioral health issues. So I work together with high school students on community behavioral health projects, and we get the teachers involved. So we start this idea that we always work together. We always learn from each other. And I think I've seen it work, and I believe it could work really, I think it could work globally, but like any good clinical scientist, we need to get the data and to see how we can do it best. That the data is what matters, not just our own personal attitude or opinion. If students want it, I think they can begin the role. And then when you become the leaders, as you go on in your career, then you can say, we need to do more of this. So I believe now is the time to start it. And I believe that as it demonstrates its success, it will only grow. And I'm pretty confident of that.
Thank you very much. I understand we are going to establish this IPE at international level. This is the second of our series. We had started with Dr. Sartorius in March, and here we are together with you. And next month, we will have 3 colleagues, one Dr. Afzal Javed from the WPA, and Dr. Parameshwara Deva from Malaysia, and Dr. Unai Zanias from Pakistan. Maybe they may have a look at this discussion in the YouTube, and we can try to develop something in the future. And as you know, tomorrow we will have a meeting at Section on Psychiatry, Medicine and Primary Care of WPA. We may also bring this topic up there. Before going to Jenan, while you were presenting, I had thought of PBL, problem-based learning, just with cases and discussions without a lecture, but with a facilitator. But what you have added to this is having different medicine, not only medicine, but different health disciplines together to discuss this. Are there other examples of this in other places of the United States or other countries?
Well, PBL, as you know...
No, I'm not asking PBL. I'm asking your approach.
Oh, yeah. No, it's actually gaining in popularity. So we're seeing more and more. I've been able to present on this at a number of different national forums. So we're seeing a strong interest and involvement in this. So we're seeing actually many schools are now adopting some form of this. The brilliant question that the student asked about fitting this into the curriculum, I think